So today's topic is Pleuraleffusion, Empyema, and Pneumothorax. What is pleura? Pleura is a serous membrane that is covering the lungs. It has two layers, visceral layer and parietal layer. Visceral layer is the one that is covering the lungs and opposite to the lungs. And the parietal layer is the one that is lining the thoracic cavity. So this diaphragmatic representation, this pleura has four parts: cervical, diaphragm, costal, diaphragmatic, and mediastinal. As you all know, the visceral layer is the one that is covering the lung, and the parietal layer is the one that is opposing the thoracic cavity. So the area between these two, parietal and visceral pleura, is very thin in costal area, cervical, and mediastinal. Whereas in diaphragmatic area, it is a bit larger. So as you all know, the lower quarter of the lung is in the 6th space in mid-clavicular line, 8th in mid-axillary line, and 10th in mid-scapular line. Whereas in pleural layer, the lower part of the pleura is in the 8th in the mid-clavicular line, 10th in mid-axillary line, and 12th in mid-scapular line. So this space in the lower part is between the visceral pleura and the parietal pleura is the osteo-diaphragmatic races. This races is deepest in the axillary area. This is about 9 centimeters in the axillary area, and this is the place where the collection of any collection in the pleura will start from this races, osteo-diaphragmatic races. And once it is filled up, then only it goes up into the other parts. So normally, the fluid enters the pleural space via the capillaries in the parietal pleura and is removed by lymphatics. A lubricating fluid will be present in the pleural space. The fluid can also enter the pleural space via the visceral pleura from the interstitial spaces or from the parietal cavity through the defects of gum. But from wherever the fluid comes, it has to be removed by lymphatics. These lymphatics have a capacity of about 20 times the normal fluid absorption than the normal fluid levels. So any excess of fluid that is accumulated in the pleural cavity is called pleuraleffusion. So whenever there is pleuraleffusion, initially the lower diaphragmatic disease, osteo-diaphragmatic disease will be built up, and slowly it causes the compression over the lung and the lung collapses. So what is the etiology of pleuraleffusion? So it can be due to increased formation of fluid or decreased absorption of fluid, or can be combination of the two. So increased fluid formation may occur when there is any increase in the intravascular pressure in the pleura. If there is increased intravascular pressure in the pleura, there will be pressure gradient, and hence the fluid will be sequenced into the fluid sequence occurs into the pleural cavity. There is permeability of capillaries may increase in pleura in case of whenever there is any pleural diseases or inflammations or infections. The abnormal permeability of capillaries will be there, and the fluid may come into the pleural cavity. The other is increased fluid from the peritoneal cavity also may enter into the pleural cavity through the diaphragm. Then interstitial fluid increase when there is any parenchymal infections in the lung, pneumonias and all. In that case, there will be increased interstitial fluid formation, and this interstitial fluid may enter into the pleural cavity through the visceral pleura. And then any injury to the thoracic duct or blood vessels or a disruption of these two may cause collection of fluid in the pleural sac. And the thing is decreased fluid absorption. So similarly, when there is formation or increased, or if there is decreased absorption, as in case of obstruction lymphatics. So as the lymphatics are ones that remove the fluid from the pleural cavity. If there is any obstruction to the lymphatic drainage, there will be collection of fluid in the pleural cavity. The other is systemic vascular pressure elevation also may restrict the lymph movement and thus cause accumulation of fluid in the pleural cavity. So what is the clinical presentation of pleural effusion? So as I told you, the collection occurs in the lower part in the diaphragmatic basis, post-diaphragmatic basis, and slowly it goes up. Once this basis is completely filled up, the fluid may cause a slow compression of the lower part of the lung. The alveoli will collapse slowly, and thus as the accumulation occurs, slowly the lung will be collapsing because of the compression. So what are the symptoms of pleural effusion? So whenever generally with the patient with pleural effusion, we come people with dyspnea only. Patient will present with dyspnea. Dyspnea is breathlessness. So when the patient comes with breathlessness, which is increasing, progressing slowly, we have to inquire into the history. And during the history, we will get an history of chest pain, initial chest pain, and with the dry cough. So whenever there is an impuritic state, in the initial states of accumulation of fluid, due to irritation of the parietal tuba, there will be stabbing, sharp chest pain, which is increased on deep inhalation, which may subside after once the fluid collection occurs. So initial stages in 1 or 2 days, patient may get pleuritic chest pain and dry cough, and later once the collection occurs, the pain will disappear and patient will have slow accumulation of fluid will cause progressive dyspnea. So these are the symptoms of the pleural effusion. The patient may present with dyspnea, which is progressing in nature, maybe giving history of initial chest pain and dry cough, which subsides after some time once the dyspnea develops. The physical examination shows decreased movement of chest. As you all know, when there is an accumulation of fluid in the chest wall may be difficult to move. So the decreased movement of the chest and dull to stony dull note and percussion. Air will cause percussion, note is resonance. Whereas fluid will cause dull note or stony dull note. And there will be decreased or absent breath sounds on the affected side. The initial states where there is pleuritic chest pain, at that stage there may be some pleural rub in the chest. Investigations. What are the investigations that you are supposed to do when you suspect pleural effusion? First and foremost is chest X-ray. When you get an X-ray done, X-ray will show opacity in the absence because of the lung collapse. The absence of air entry will be there, and fluid will show an opacity. And pleural fluid aspiration. Once X-ray confirms the diagnosis, then we have to send the fluid, aspirate the fluid and send the analysis. And in case of some conditions where there is minimal fluid, or when you suspect any lacerations, or when the fluid is not present, there is dry tap, in those cases, in pleural effusion also, we need an ultrasound test or CT scan test. So chest X-ray, the chest X-ray air shadow will be obscured, and there will be an opacity. So this quantification of fluid can be done with the chest X-ray itself. So this is Ellis S-shaped curve. In 1874, Ellis described a sign, that is, whenever there is a pleural effusion, the rising line of dullness will be there from anterior to posterior with rising in the axilla. So as you all see here, the opacity, the pleural effusion line will be rising in the axilla. This anterior to posterior, there will be rising line. This is called Ellis S sign. So this is the X-ray showing various stages of pleural effusion. This is a minimal effusion, blunting of CP angle, prosophenic angle. This is moderate effusion with minimal displacement of the mediastinum, and this is the massive effusion with complete displacement of the heart to the right side. So once the diagnosis is done, pleural fluid analysis should be sent for. What is the test that we do for pleural fluid? Once the pleural fluid is aspirated from the pleural space, we should send it for cytological, microchemical, and microbiological investigations. Cytological for malignant cells and TCDC. Biochemical is for sugar, protein, lineage, and ADA. And microbiological for gram stain, AFB, and culture sensitivity. So based on the composition of the pleural fluid, the pleural effusions can be exudative and transudative. Exudative effusions are those with underlying some disease process, and transudative effusion is mainly because of the present gradient across the capillaries. So exudative effusions have a classical differentiated from translate by Light's criteria. What is Light's criteria? Pleural fluid protein as serum protein ratio is more than 0.5. Pleural fluid LDH and serum LDH ratio is more than 0.6. And pleural fluid LDH is more than 2/3 of upper limit of normal LDH. If any of these criteria are positive, then we have to say it is exudative effusion. Otherwise, we have to say it is transudative effusion. Exudative effusion occurs in some disease process due to some disease process, whereas transudative effusions are because of only preservative across the capillaries. So the other investigation that we do is ADA, sugar, and cytology. ADA is increased in tuberculosis, decrease in tuberculosis and empyema, whereas in cytology, we have to see for lymphocytes. If the lymphocytes is there, we have to suspect tuberculosis. If it is neutrophils or more, then we have to suspect any paraneoplastic effusions. In case of any malignant cells, we have to think of malignancies. Sugar levels are decreased in cancer and pains or bacterial infections. So, what are the causes for effusions? For transitive effusions, where the pressure gradient causing the effusion, there will be occurring in any generalized encephalopathy cases like congestive heart failure, nephrotic syndrome, cirrhosis of liver, Meek syndrome, hydronephrosis, and periodontitis. In all these systemic conditions, where there is generalized accumulation of fluid in all serous sacs, the pleural effusion also can occur. In case of exudative effusions, the commonest is tuberculosis. The other causes are tumor, trauma, pneumonia, radiation, dozen diseases, sarcoidosis, emboli, as well as causes of leukemia. All these causes are the causes for effusions or exudative effusions. But commonest is tuberculosis. Similarly, for transplanted effusions, commonest is CHF. Tubercular effusion is commonest in exudative effusions. And pathogens, it can occur because of the sequelae of the primary tuberculosis. It can be due to any reactivation of the focus. It can be due to delayed hypersensitivity, or it can be due to any rupture of subpleural calcareous focus into the pleural cavity. So, once the diagnosed pleural effusion, how to approach the case? So, once the pleural effusion is there, we have to do a diagnostic pharmacosynthesis, that is, pleural fluid is aspirated and is sent for analysis for protein and LDH. Protein and LDH to root out Light's criteria. If any of the Light's criteria are met, then we have to say it is exudate. If it is not there, then we have to say transudative. So once it is transudative, we have to treat the cause, that is cirrhosis, CHF, or nephrosis, whatever it is, we have to treat that cause. If it is exudate, then we have to go for other investigations like glucose and cytology. If it is glucose less glucose less than 60 milligrams, then we have to think of any malignancy or bacterial cause. Or if it is cytology showing lymphocytosis, then we have to think of tuberculosis. And if it is neutrophilic, then we have to think of bacterial causes. And if nothing is there, then we have to suspect any embolism. So we have to go for spiral CT. And if it is a pulmonary embolism, then we have to treat the pulmonary embolism. And if it is not present, if any of these are not fitting into it, then we have to go for thoracoscopy and pleural biopsy. Now, once treatment, pleural effusion, as it is not a single disease entity, it's a part of disease entity. So first we have to treat the underlying cause. It can be due to transudative, or if it is transudative effusion, we have to treat the underlying systemic cause. And if it is exudative effusion, we should treat the effusions infections. So we have to do the both. If it is transudative effusion, only treating the underlying cause is sufficient. We need to go any aspiration of pleural fluid. But if it is exudative effusion, we have to go for pharmacosynthesis. Photosynthesis means the aspiration of pleural fluid. So aspiration of pleural fluid, first of all, first step to do is you have to do selection of site. By doing percussion, you have to mark the area of maximum dullness. Once the area of maximum dullness is identified, then you have to put the needle in the upper border of the lower lip. Intercostal space has two borders, that is upper lip and lower lip. Any lip has an internal surface, there is a grooving on the internal surface of the lower border, where it lodges the neuromuscular bundle. So, if you introduce the needle in the lower border of the lip, then you will be causing damage to the neurovascular bundle. Hence, you have to always take a precaution that needle should be introduced in the upper border of the lower lip of the intercostal space. So, this is a three-way cannula that is used for the aspiration or thermosynthesis. Aspiration of fluid is called thermosynthesis. So, in that, this is three-way. There is this three waves will be there. This is for needle, where we put it in. This needle will be fixed and it is put it in the fluid cavity. And this is the syringe. This is the place for syringe, and this is for the tubing to draw fluid into the bottle. So this is the lock. If lock is in this direction, you can draw the fluid from the pleural space to the syringe. And once the lock is turned this way, and if you push the fluid into the cannula, then the fluid will go into the connecting bottle. So this is required because the atmospheric air may enter into the pleural cavity if you open the pleural space to the atmospheric air. So you have to use a three-way cannula to avoid the exposure to the atmospheric air. If the fluid is in star color, then you should suspect tubercular effusion. If the fluid is in the yellowish and thick turbid, then it is pus, and it is called empyema. If the fluid is blood, it will be called pneumothorax. And if it is a milky white color, and it is called Pleuraleffusion. What is empyema? So empyema is, as I told you, it is a pus collection in the pleural cavity. The conditions that cause empyema are pulmonary infections, surgical procedures, trauma, spontaneous pneumothorax, tissue penetrations. Photosynthesis also may cause empyema because of aseptic, if you won't take aseptic precaution. And subdiaphragmatic infection may enter the pleural space as well. So these are the conditions where you may develop empyema. So what is the evolution of empyema? Empyema is three stages. First is exudative stage, where there is only outpouring of sterile pleural fluid. This is a stage where there will be exudative effusions only. If the patient presents at this stage, a patient with antibiotics will be relieved of the disease, and there won't be any pus formation. But if the stage extends to fibroproliferative stage, the patient does not come to doctor, then bacterial invasion occurs into the pleural fluid, and fibrillation of fibrin and membrane occurs, and there will be locular formation in the fibroproliferative stage. If the patient presents at this stage also, it's up to some extent, patient will be treated with higher antibiotics and easy treatment will be done. But if the patient delays even further, then it will go into organization stage, where the fibroblast grows, forming an elastic membrane called pleural peel. Thick fluid will be there, and pleural peel formation will occur, where there will be shrinkage of chest wall because of the fibrosis. So chest wall narrowing will be, crowding will be there, shoulder will be tipping, and mediastinum will be pulled to the same side. The bacteria causing empyema, Streptococcus pneumoniae, Staph aureus, Mycobacterium tuberculosis, Proteus species, Pseudomonas, E. coli, Klebsiella, and bacteriologists. The clinical manifestations of empyema are any condition where there is pus in the body, It is sepsis. So there will be acute febrile illness along with pain. Pus causes pain. So whenever there is pus collection in the chest, there will be chest pain with fever. If the condition is associated with some parenchymal disease, then only we have cough and expectoration. Otherwise, patient may not have cough and expectoration. The signs will be intercostal tenderness because pus causes